So here we are having heart. So it's interesting that as I was saying, I mean, it's like the third time in a row I've done this. So we should be able to get through this fairly easily. And really, we should be able to finish this chapter. And as I was saying, then in the lab, I just want to get blood started. It'll be just me lecturing for an hour and 10 minutes. You can get yourselves out of here. I'm tired of listening to me drone on forever. And because I wanted to, we have a wet lab in blood that with this preparatory stuff, well, we can get started with it afterwards and go from there. All right, we're good. So this follows what we were talking about a little bit. I think. Oh no! I can't do it. Oh! I gotta finish endocrine with you. We'll do this, the hard thing in the way. It's okay. I'm sorry. Never mind. Ignore me, which you do anyway. I'm eminently ignorable. Even I ignore me. My wife certainly ignores me. Joyously. We were doing endocrine. Why didn't you tell me? Oh, he's a doofus. Okay, I sent you 2 recordings. I sent you one to conclude 15A, which basically did the pituitary, and this one. Oh, today's a diabetes day. Yes, something different. Yeah. To diabetes, we'll put some sugar on it. Poor sugar. We did thyroid and parathyroid. Oh, and I thought I was going to have to do the heart again. I gives me a break. But we'll get the blood thing. We'll get that going. I'll address that Wednesday and Friday because it comes after endocrine. And happy dance. And like this is just telling you the thyroid does everything. And we talked about goiters, exophthalmic. So if you listen to that, and I did it by intent because it's very straightforward material. There's not a lot going on. And where I left it, and I had forgotten about it, so it all of a sudden dawned on me, the adrenal glands, which lead nicely into pancreas and diabetes. So voila, adrenal, above the renals, often called suprarenals, the name of the artery, you might remember from anatomy, it's a suprarenal artery. You have 2 areas. The adrenal medulla we addressed. Okay, to me, that's not part of endocrine. It's endocrine-like in function because it deposits epinephrine and norepinephrine directly into the bloodstream. I'll buy that. But really, it's activated by and really it's just to me it's a misplaced ganglion in the autonomic nervous system. Most anatomy and physiology teachers agree with that. We're talking about the 3 layers of the cortex. They have wonderful names that you don't have to know, but it's fun. Okay, and 24 different hormones collectively called corticosteroids. We're just going to go with the majors that are here. They're not stored in the cells, and so the rate of release depends on the rate of synthesis. When it gets that signal from ACTH or other factors, it releases these. So 3 layers of the cortical cells produce the 3 different steroids. The fancy names are glomerulosa, and this is from outside the inner peripheral to central, the glomerulosa, the fasciculata, and the reticularis. Don't have to know, but it's just thorough to teach it to you. And we collectively refer to them as mineralocorticoids because their basic activity is controlling water balance and sodium. Glucocorticoids because they impact glucose and the release of glucose in a number of areas. And finally, and lastly, gonatocorticoids, which are principally androgen substances. These are really, when you look at where some of these laboratories, famously Balco and the ones that have been implicated in performance-enhancing drugs, this is the kind of testosterone-like precursors are made. And interestingly, this is the only area in the female where they make testosterone. And so, and it does, and it has a certain amount of effects. Other than that, and again, even there are some testosterone-like substances some estrogen-like substances that the male produces, but here, this is the one real area, and it's part of that underlying factor that we discussed, or will discuss with blood, rather. That is why we tend to see blood counts lower, red blood counts lower in the female than in the male. Menstruation during the childbearing years is a factor, and the fact that there's really a very limited amount of testosterone-like substances, which certainly stimulate the bone marrow to produce red cells. So voila, here we go. Here's what they look like, the layers. When we get down here, and you don't have to know anything about the slides. I don't think it's that terribly relevant. So mineralocorticoids, just what their name expresses. So, and I want you to understand going in that when you have agents that, when commercially we utilize certain kinds of steroidal agents that come in this, there's overlap. Mineralocorticoids have some glucocorticoid activity. Glucocorticoids have some mineralocorticoid activity. So it's very rare that we see them in a pure sense. They overlap. And I'm giving you that from a clinical basis, which is important. For years, and you may not be as aware of this as, because it's not done as much today. We have a whole other way of treating different, typically autoimmune diseases, and maybe you're getting this in immunology. We had very limited resources to treat. Now we make a whole slew of biologicals that I'll talk about when we do our immunology unit, that are made in the laboratory, made genetically, that, are used as, a variety of interleukins and combating them, tumor necrosis factor, IL-17 inhibitors, blah, 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 blah. Years ago, the only thing we really had was a very limited group of treatments for people with rheumatoid arthritis or lupus. Most of the time it involved prednisone and maybe a few historical agents. One I took for quite a long time called sulfasalazine, okay, which has been around forever. We still don't know how it works. Long story short, one of the problems when we had to have people on long-term steroids like prednisone or prednisolone was they had mineralocorticoids. So we had fluid retention problems. We had a variety of things attended. And I'll be going into that as part of this PowerPoint. So they did, the pharmacology has changed significantly. You're going to ask me if it's for the better. I don't know. I'll give you my spin on that. And it's framed as opinion because I stopped taking 2 of those because I actually feel better without them. It's amazing how eating better and exercising helps. Don't tell anybody, it's a secret. So regulate electrolyte concentrations, primarily sodium and potassium. Again, sodium and potassium go in opposite directions. So it's in the extracellular fluid. We know how important they are, resting membrane potentials, etc., etc. Sodium, again, Stein's Mary had a little lamb rule. Where sodium goes, water is sure to follow. You'll get that in MCAT yet again. Okay, extracellular volume, blood pressure, the fluids, and it also impacts indirectly because sodium helps to co-transport and anti-transport. We have potassium, hydrogen ions, bicarbonate, chloride, all are involved with the mineralocorticoids. And we know about the potassium sets the resting membrane potential. Aldosterone is the big player. Okay? By far and away the most potent, really the one we have to talk about. How does it work? It stimulates sodium resorption by kidneys. When we get to the kidney, you're going to see the kidney produces a chemical called renin, R-E-N-I-N. And renin activates, so we'll write it again. I'll write it 10,000 times. Can't write it. Renin, angiotensin, aldosterone. Renin is the catalyst. It changes angiotensinogen, okay, inactive form, into the active form, angiotensin. So that we still have to activate it. So we have 2 steps of it, in fact, in activating it, that eventually play a role in leading to a spinal activation as angiotensin 2. That has 4 different activities that raise blood pressure, 4 ways. I'm trying to simplify it to save myself. I can explain it better than writing, my bad handwriting. And this has to do with something called angiotensin. We deal with this in blood pressure, we deal with this in kidney, angiotensin converting. Which interestingly occurs in the lungs. It's actually a 2-step activation. But without going crazy about it, one of the ways, and the most significant way, that angiotensin 2 works, it stimulates the release of aldosterone. And the aldosterone, the principal way that it works, it inserts into the collecting ducts, which you might remember from anatomy, and into distal areas of the distal convoluted tubule, little channels that will basically cause sodium to be retained or pulled out of the urine to filtrate, and then water follows. So that combination of sodium and water increases blood pressure, increases basically extracellular fluid volume. And at the same time, when sodium's going in, potassium's going out. Same kind of relationship calcium and phosphorus have. They tend to go in opposite directions. So stimulates potassium limitation, increases blood volume, and increases blood pressure. Voila. So very short-lived. The sodium-potassium pumps, sodium for potassium, where they occur, typically in those areas in the distal convoluted tubule and in the collecting ducts. And so the renin-angiotensin-aldosterone mechanism plays a role. If you have high concentrations of potassium, that will activate. Potassium is bad news when it gets out of control. ACTH, the principal means of from the pituitary, and what sort of functions against it when we get to it from the heart, if there's too much fluid, there's a phase where the atria are filling, which we're going to get to in the heart. And in that particular phase, they stretch a little bit. If they're filling too much and stretch, that means there's too much fluid in the system. And they release something that we use the acronym ANP for atrial natriuretic. Natri means sodium. Uretic means to get rid of. It's like the anti-aldosterone. So basically, it encourages sodium to be excreted in the urine, and water follows. Stein's Mary had a little lamb rule in action. There it is. Stimulates special cells in the kidneys. You're going to come to know. They're called the macula densa. And those cells will generate little granules of renin, okay, into the blood. The renin breaks apart that angiotensinogen because it's in a precursor state. Typically, that's very true for a lot of active products. They're in precursor states. We call them ogens, and eventually gets to angiotensin 2. That's the big player. Increased potassium directly will stimulate aldosterone. Low levels, by the same token, inhibited. Again, if we have low levels of potassium, we certainly don't want to lose more potassium. Getting too low in the bloodstream is an absolute nightmare. ACTH, okay, designed for stress. For years, ACTH we were able to. My dad used to get ACTH injections because they made him, quote, feel better. And I'm not quite sure. I love the doctor, our whole family doc, but I don't know how much it was traditional medicine. It was like, if it made you feel better, he just did it. I don't know how scientifically accurate he was, the whole family doctor. Okay. So I did not know if he had a lack in it. I was very unfamiliar with it, really, until he died, understanding a lot about what was going on. Kids sometimes ignorant about parents. And so it would get him, he would feel better. And I really wonder if there was some limitation in his ability to cope with the stress. I never quite understood it, but yeah, maybe it may have related to blood pressure. Maybe he was running low. Here's the atrial natriuretic peptide. in response to high blood pressure because it's stretching those atria and blocks renin and aldosterone secretion to decrease blood. And they just give you this idea, and you can go through the chart the way I can. Typically, if we have an increase of this, we're having an excessive amount of secretion. Usually, tumors are the underlying cause. And what is the result? As you might guess, you have too much fluid, so you end up with high blood pressure. And unfortunately, whenever you have, effectively, blood vessels are still blood vessels. You remember from anatomy and physiology, from the anatomy portion, blood vessels have capillaries have little pores. If there's fluid builds up a pressure, it's going to ooze out in the pores. It just is. So long-term complications eventually is it damages those blood vessels, and the pores and the openings, those little tight junctions aren't so tight. And we get more and more fluid coming out. Gravity plays a role in it. Lower extremity is typical an area where we see it, but it accumulates in other areas. Okay. Excretion of potassium leads to abnormal non-responsive nerves and muscle. So that's the problem. I mean, we're dealing with some, this is a major, significant problem, hard to manage. Glucocorticoids. Now we're into that next level that's a little, whatever that is, the fasciculata, the next level. So this is probably what helped, maybe if I'm thinking about my dad's stress, it was probably the ACTH which influenced this more than anything else. Because generally what we do is we respond by ACTH increasing something we respond to naturally at times of stress. And so it's there to maintain your blood glucose levels, hence the name glucocorticoids. Their principal action, okay, they do play a role as vasoconstrictors. Okay, so it's sort of, think of it as augmenting the role of the aldosterone. That's a different mechanism. Aldosterone doesn't have anything to do with making the blood vessels more taut. The glucocorticoids do. The one that is the active one in us is cortisol. We utilize these. If you want to see, this is in humans. We find this not only but pharmacologically, we basically we tinker with these cortisones. Prednisolone, methylprednisolone, is typically the one, if you ever had to take a dose pack, that would be the drug. Most people are familiar with a dose pack for like poison ivy or something like that. But nevertheless, cortisol is the active portion, really to be familiar with. It's in response to the ACTH and ACTH, and we have levels of it. It's so important to understand. When we utilize steroids for treatment, which really, and I commented on this in one of the dictations that I did, one of the recordings that I did, is that we were so careful when we had people on steroids, because it was used a lot. I mean, I was operating up, I've been operating for 25 years. We had a lot of people, those biologicals were in their infancy. Okay. People were still using a lot of that, and you had to taper them off with steroids. And steroids, you always tapered off in the morning because you didn't want to affect the mechanism of the release of ACTH. So the last dosages of a dose pack, or if you're you're basically instructing patients pharmacologically, we always made the last doses in the morning. So if we take it over 10 days, maybe the last 2 days, morning only. You don't want to take them in the evening because your system is geared to release steroids, whatever your morning is. And the morning varies as to what kind of job you have long term. For most of us, it's a daylight type job, but not everybody. So it varies with your own sort of biological. So basically, and normally it's low cortisol levels, typical negative feedback. Again, patterns of eating and activity probably is the big role. That's where the clock kind of gets set, if you want to think of it this way. And there's so many things that interrupt it. You'll see levels increase with infection, certainly physical trauma. We underestimate the role of emotions and psychological stressors. Okay? And we can have CNS overrides as well. When someone's under stress, it's you should see it yourselves by this time. And I'm not saying you don't. I mean, but you should see what people are. They're stressed out. Yeah, to me, I kind of give them a pass a little bit, unless they're, perennial offender. You know, okay, this happened. There's something bad happened in the family. We're all familiar with this stuff without itemizing it. You kind of go, okay, they get past it. I mean, we're saying that a lot with my mom's funeral, my mother-in-law's funeral. No. So while I lost my track of it. Cortisol, mostly gluconeogenesis. I don't have to explain gluconeogenesis to you because you have or had Dr. Hillwig. She's in love with it. I know, but she's still in love with it. Primary effect is gluconeogenesis from new sources, fats and proteins. Cells to use fatty acids, so glucose is safe for the brain, makes sense. And then, yes, there is a certain amount of vasoconstriction, okay? And that's more about if you think of it with distributing nutrients. It's a good thing. Excessive levels, bad. Understand when someone gets a shot of cortisone, when they're injecting an athlete for a knee, okay, when they're injecting grandma for a knee or a hip, they're giving them a cortisone derivative. It's generally a combination of two types. It's one that works immediately and one that is longer lasting. And they're in combination. I don't even know what the ones are today. We used one called Celestone Soluspan, which was made by Sharon Plow, and it was a nice mixture. And the trouble was, if you weren't careful, we would find if you excessively inject, about 3 times a year is about as much as you want to inject. With people who were being injected more frequently, when we opened up their knee to do surgery, we found little white particles of undissolved cortisone in there, and all it's going to do is tear things apart. And you never want to do those on tendons; they weaken. I can't tell you how many studies were done on rupturing Achilles tendon. People used to inject Achilles tendons for tendonitis. Ugh. I had with my patients what I call the rule of Lou. The rule of Lou was that if you're younger than I am, I'm not sticking cortisone in you. Would not apply now if I was still treating people. They'd all be freaking younger than I am. But when I was in practice, it's roughly between the ages of, let's say, 30 and 50, plus or minus a couple of years on either end. My patients are mostly older. So they can damage bone. Okay, they inhibit inflammation. Think of it. What stabilizes our cell membranes? Cholesterol. These are made from cholesterol. The mechanism is not clear why it stabilizes the membranes, but that's the way I remember it as being why it's so potent as an anti-inflammatory. We use it all the time. Okay, inhalers. We have albuterol, and a lot of times if it's for prolonged allergies, you're going to be using a cortisone-based inhaler. I sprayed my nose a couple of times with that same stuff. Okay, today you can buy it anywhere. Those nasal sprays are now totally, found without prescription. They're very, very useful. It's a lot better than using what we used to use because they would damage the membranes and dry them up. We used to use like phenylephrine or neosynephrine. All those, they caused more nosebleeds, more trouble than they were worth. They were addictive. We had like a rebound phenomenon if you didn't know that. So these cortisone-based sprays and saline-based sprays for people with allergies and things like that, very helpful. They do depress the immune system. That's why they were used so much in autoimmune phenomena. Strike me as none of that would be good. But all the side effects are the problem. And then we deal with some of the problems that are associated with it. There are 2 that you should be. This is called Cushing's syndrome or Cushing's disease. Not clear what causes it, but it impacts bone. It impacts the immune system. Okay, you would think, well, it doesn't. It's going to make your immune system. If it slows inflammation, it means your immune system is less active to respond. So we used it, and we saw it. Cushing-like syndrome events when people were being treated with very high levels of prednisone. You might remember telling that anecdote about that young woman with Meniere's disease, an autoimmune disease, who just, I mean, in a year, she was unrecognizable. She had gained so much weight and was almost, I can only imagine. That was all they had available. I do not know if they have anything to treat that now. And all the function. Typically, tumors could do it in any of these areas. This is the one that would see, this overuse of corticosteroids. And if it wasn't from that, then it was a pretty serious sign. And typically, for whatever reason, fluid tended to accumulate here and almost developed like a fluid accumulation that almost appeared fatty, and then this enlargement of the face that was there. And you had to get these people off the drugs. They'll show you, I'm sure they'll have the illustration. If they don't, just Google images for Cushing's and Buffalo Hump, and you'll see the same illustration they always use. This gal actually looked like horrible, absolutely horrible. So you don't have the context for it. Well, I told you about muscular dystrophy. The guy who ran the telethon for umpteen years ago was a comedian who was not the world's greatest comedian, but very, very interesting. And Jerry Lewis, he was on, for breathing problems, was on high levels of these. This is all they had available, and he was unrecognizable in his later years. Finally got off of them, and then he became recognizable. He was like a totally different person. Here's that. I'll get to it. This is showing you the excessive before, after. You see the hump that's there. You can see the lack of definition, cheekbone wise, et cetera, et cetera. Addison's disease, very interesting. Deficits in glucose and mineralo, decreases in plasma glucose, and so as you might guess, if you're not making enough of these, one maintains sodium, one maintains glucose, or keeps it relatively level. Weight loss, severe hydration, treatment, corticosteroid replacement therapy, yes. Bronzing of the skin, because what happens is those low levels, for whatever the reason, ACTH triggers, and you might remember areas in the pituitary where it triggers melanocytes, so they became pigmented. Did I tell you the story about JFK? No. John Fitzgerald Kennedy, the late president, obviously he was assassinated. I suspect, based on what I know about his medical record, he wouldn't have survived 2 terms, and he surely would have been reelected. Because his successor, LBJ, won in a landslide. I think only one state voted for Barry Goldwater, and that was Arizona. He was from Arizona. Let's see. JFK was people don't know. He literally, his PT boat in World War II in the Pacific was torpedoed itself by a submarine. He and maybe his whole crew were in the water. They had to literally buddy swim people to an island just to get them out, and the island had nothing there. And so not only was he carrying people with him to the island, eventually he had to swim. They had to find another island that was closer so that he could somehow get help. And here's this guy he was in command of that vessel. He was a Lieutenant JG, just a second level officer, and did these swims. Basically, imagine how physically fit you had to be. Little did they know he had Addison's disease. When he was elected, people marveled. They were this gorgeous couple. He was slender, and whatever you define as handsome, always looked like he had a great tan. Addison's disease. He was taking a bunch of medicine. I mean, I won't get into his behaviors, which weren't very good. He made Bill Clinton look like a parish priest. Just saying. But notwithstanding, and there's no secret to that anymore. But it was. Could some of it have been involved with the medications? I don't know. That kind of behavior, I wouldn't give a pass to. But you should be familiar. Here's the gonadotropins. Oh, heavens, I'm not getting enough time to get diabetes. So Male sex hormones converted to testosterone. The Mark McGuire incident, used to be able to buy from like GNC, androstenedione. A reporter, when he's hitting 70 home runs, finds a giant jar of this in his locker, in the St. Louis Cardinals locker room, in McGuire's locker. Hello? It's like, really? But at the point, it really wasn't quote unquote banned. It was it's awful. I don't know what you think about those records as more of a purist in baseball, and even the world's biggest Barry Bonds fan. No, thank you. You know, but this was really where a lot of those came from. Onset of puberty, secondary sex characteristic. Interesting, they think sex drive in women. And again, whenever you see a May permissive term, it's not the same we know testosterone in men definitely are part of puberty and secondary sex characters. Whenever you see a permissive term anywhere, it's code for we don't know. Okay, and again, so there's some of these where there's hypersecretion, less notable in male. You can imagine in boys, early onset of reproductive maturity, secondary sex. In females, masculinity, etc., enlargement, clitoral enlargement, etc. So you can imagine it's more attendant with problems there. You don't see this again. This is the medulla. I don't really count that per se. That's a very famous tumor that we look at, these chromaffin cells. It's called a pheochromocytoma. You'll hear it if you go into medicine. You'll hear about it. Doctors will be always looking for it. Can't wait it's a rare tumor, so you want to get a patient with it and write a paper. Not good for the patient because they overproduce these catecholamines. Okay, and this is an interesting example to talk about. It's years ago, epinephrine-like products. The parent of epinephrine is a chemical called ephedrine, which was originally how amphetamines were made. And ephedrine was an herbal extract from a Chinese plant called the ephedra plant that led to bronchodilation, why it was so useful for breathing. Albuterol is better. And they found out that not only did it do that, it suppressed appetite, okay, and it increased, people increased their degree of activity. It was the parent of what steroids were. Not steroids, what amphetamines. Yeah. So understand the interesting thing about that, the bronchodilation and blood flow to the skeletal muscles and heart is good. The problem with it, the epinephrine was useful. The norepinephrine that's released into the bloodstream had a very distinct effect on this. And so these compounds, and the one I'm thinking of is called Metabolife, and another one you could get at GNC easily. And it was a dietary supplement for dieting because it covers your appetite. And there were two significant cases that caused death in athletes. An all-pro tackle one summer, I'm going to tell you maybe 03, 04, and Corey Stringer. There was still a giant lawsuit. They were doing 2-a-days in pads, and it was an unusually hot summer up in wherever it was in Minnesota for the Vikings. And this guy keeled over with hypothermia and died. He was 6'4", 377. They had him on that kind of a diet pill. Perfectly go to the GNC and get it. And he became hyperthermic, and they couldn't resuscitate him. They couldn't revive him. And then the next spring training, an Orioles pitcher was a rookie, but very overweight. High up in the Rookie of the Year voting. Same deal. Down in spring training, heart attack, died. And periodically they would take it off the market and put it back on the market. Don't know why. So that's interesting as an aside. And so again, it's a gland that really copes with stress. Okay. I would think there would be a problem with hyposecretion, but it could be compensated. Okay, and then the hypersecretion, there's the pheochromocytoma. All of those things are bad because they're mimicking fight or flight, and really blood pressure crisis would, to me, and then the eventual problem with heartbeat and leading to arrhythmias would be potentially life-threatening immediately. And he has a useful chart for this. Can't say much about the pineal gland. melatonin, may affect. Okay, we think there are certain rhythms that are associated, biological rhythms. So it's almost like we know it makes melatonin. So it does play a role in sleeping. But a lot of these things, different cycles that we have that are both daily cycles, monthly cycles, annual cycles, these different, we call circadian rhythms, play a role in this. Uh, Slow rhythmic variations like that. That's where the melatonin came in. Does it have antioxidant? There's a lot of we don't know about it. I would hate to ask somebody specifically about that. And they're just showing you the locations. This brings us, at least I have, I have 10, 15 minutes to introduce the pancreas. Double duty glands, exocrine and endocrine, just like the gonads. The exocrine function, very simple. There's a duct. You might recall it from anatomy that leads directly in to the duodenum, the common bile duct that's there. And that basically is producing a variety of digestive enzymes, all exocrine in nature because it goes by way of a duct into the alimentary canal. Versus the islet cells. So you have three types of islets, alpha, beta, and delta. I'll cook up the other PowerPoint. They don't go into the delta. It's not relevant for us, but it is certainly another hormone that's produced. Alpha is and this is classic, things that you do need to know. Islets of Langerhans, or just somebody will say the islet cells. So you have alpha, make glucagon, works on the liver. You all know about it. Causes the release, cuts up glycogen, glycogenolysis, stimulates gluconeogenesis, right? And the beta cells, insulin, which lowers the blood sugar because it brings it into the cell for energy transformations, and it targets nearly all cells in the body. A biggie. Don't care about that. Very potent, triggered by decreased blood glucose levels for sure. Amino acid levels, typically that's something that we see interesting when somebody ingests a meal. So the neat thing about these two is they're not mutually exclusive. The fact that you're releasing insulin doesn't preclude releasing glucagon, and indeed, they are released together. Because as you will learn when we engage in the diabetic discussion, which I think would be better suited for a lecture on Wednesday, is this: living systems don't make sharp turns. We don't see when somebody eats their blood sugar raise and then lower precipitously. Doesn't happen. It's more of a gentle kind of a curve that we see. Glucagon plays a role in that. Insulin released to eventually lower the blood sugar, but the glucagon maintains it. Okay. Those areas. So we don't see those sharp turns. When you see a system like that, I'll draw that out. That's something we used to do called the glucose tolerance test, which is still done when you're trying to analyze maintenance in diabetics. When we see sharp turns, that suggests to you a pre-diabetic. Because understand, when we talk about diabetes mellitus, sugar diabetes, it's irregular. It's characterized by high blood sugar, but it's irregular sugar utilization that's associated with persistent high blood sugar. It's the irregularity in the utilization that's kind of the secret sauce for that. And I think it's something people have to bear. It often is not talked about. I have entirely more experience with diabetic patients than I would like to. Probably 65 to 75% of my patients were diabetic. I am fortunate I am not. So glucagon, triggered by, if you go too low, it brings you back up. Fight or flight brings it up. Big meals, high in protein, it increases the glucagon release. So glycogenolysis, gluconeogenesis directly into the blood. Again, its action is on the liver. Insulin. Blood glucose levels increase, typically from meals. So we just don't eat all protein meals. So there's always some amount, always the wrong term, there's nearly always some amount of carbohydrates in a meal. If you're on a very strict ketogenic diet, You can do that without. We have done that. My wife and I have done that. Where you have very limited carbs during the day, like 20 net carbs a day is like a true keto diet. So, but without artificially doing it, basically, we're always going to have a certain amount of carbohydrate in the diet itself. And so that's going to increase blood glucose levels. It is, again, in an inactive stage, but quickly activated. And it works through those G protein receptors, has multiple effects. It's one of the ones we understood because it's been studied so much. So what it does by its second messenger system and by activating this chain reaction by way of the enzyme tyrosine kinase, you should remember that, it enhances not just membrane transport of glucose into fat and muscle cells as an energy supply, into fat cells for storage, okay? And in general, into all cells that require additional glucose for energy transformations. So it has vast effects, okay? It slows down, it opposes glycogenolysis. It opposes amino acids and fats. It opposes gluconeogenesis. So understand it has so many more effects. Again, think of it as increasing cell metabolism, increasing mitosis, increasing repair, all of which using carbohydrates as your source of energy. Remember, it's a very simple trio. Carbs first, fat second, proteins third. The way our systems are geared, unless you play that metabolic trick on it, carbohydrates are first. We utilize them, we break them down for our energy source. The whole idea of the low carb diets and keto diets, we play a sophisticated trick on your metabolism. You restrict carbs so those break down fats. And if you put enough fats in, they won't break down proteins because you don't want to lose those. But that's the batting order. For some of you, you'll understand there's another substance that's even used before those. Ready to use calories. Alcohol. That's why if you wonder why somebody has a beer belly, it's because that's now you now on top of whatever basically you're ingesting entirely too many kcals. And it starts getting, you start getting a big belly from this of it. It's okay. You don't have to worry about that. Yingling Flight, okay. Corona Premier, okay. A little Michelob Ultra. So they started manufacturing all these low carb beers. Why would I know about that? Yes, sir.
So does it increase your How still the beer guts are from
Indirectly, that would be part of it. I would agree. Yeah, it's a terrible impact on your liver. So it's think about the liver, all the things the liver does. Okay, it makes it less efficient. But from an energy standpoint, what do we do with kcals? If you make the ATP, if you don't use it in a minute, it's got to be stored. So one of those areas is part of it. I'll look at that to see, which one of those is the most impactful. I mean, I've never really seen anything in moderation is fine. And we're guilty of that. I never would eat in moderation. I didn't smoke in moderation. I didn't take pills in moderation. I wasn't addicted to painkillers in moderation. So, I mean, a lot of it. So, insulin, not needed for glucose uptake in liver, kidney, or brain. They get it natural. Yeah, plays a role, as you can see. Tyrosine kinase is that enzyme that's triggered by the second messenger system. Catalyzes glucose for ATP. We knew about that first. Makes glycogen, converts glucose to fat in adipose tissue, particularly when our energy needs are not met. So elevated blood glucose, rising blood levels, amino acids, fatty acids. These are all things that it's almost, we want to get these, so the primary stimulus. Secondarily, with a meal, you expect there's going to be amino acids and fatty acids. Acetylcholine, certainly, it's much more parasympathetic than sympathetic. And as you can see, glucagon, epinephrine, growth hormone, thyroxine, they all impact it. So they're going to have some influence as well, okay, where somatostatin, which is basically the opposite of growth hormone, but it does impact it interestingly enough. I'm not sure of the mechanism, so I wouldn't endeavor to tell you about it. And certainly the sympathetic nervous system inhibits it because you're not going to use your glucose supply for that. And I would think we should leave it at that and see everybody at 4:30 in Galileo. Thank you. Whoops.